Then there are those that arrive ahead of their time. Welcome to Penn Medicine's new pavilion.
Hey, will you bring it in? 46-year-old female, respiratory distress, blood pressure is rising. Let's get to room 2. Ma'am, we're going to take the period.
Patient room 10 in hypertensive crisis.
Get that EKG set up.
I'll be there shortly. Welcome to Penn Medicine.
Yeah, I'm trying to figure out what room my wife is in.
Good morning, sir. How's it going today? Yeah, I'm doing all right.
Good morning. Welcome to Penn Medicine. How may I help you?
Hi, can you tell me how to get to the oncology floor, please?
Yes, you'll take the patient elevator to your right up to the 14th floor.
Thank you. Wait till you see this statue over here. It's incredible. There's all these glass balls. You're gonna love it.
This sculpture is amazing. Do you mind taking my photo in front of it? Oh, absolutely. Why don't you shift a little to the left?
Exactly. Just a little bit up to the left. Just to that one spot.
I'm so excited to see him today. What flavor chip should I get?
All right, we got a cheeseburger, medium rare, ready to go.
That looks good.
760. Cash or credit? How's your rat?
Really good.
Going up.
Hang on, there's so much more to see.
Great. She's recovering right now. We're gonna get her.
Alright guys, this is John Chrisman, date of birth 1/18/1973. He is here today for a right inguinal hernia repair.
Okay, I think we're ready to scan.
A minute, and yeah, everything looks good in here.
Take a closer look at these inked margins. Can you just move it up a little and to the left? Yeah, that's perfect.
Hey, Chrissy, did you love the specimen ink that I left on your table earlier?
Yes. Is there anyone in the compound room right now?
Sure.
Fortunately, well cared for.
I hope he'll be able to come home soon.
Did you see him today? Did I get him standing? He stood. He looks steady.
Kids just wanted to check on you.
Hi, Charlie. So good to see you.
Hope you're feeling better.
Sorry about the medication for rheumatic.
After report that the surgery went extremely well. You're doing great. You can see by the scan on the screen that that was.
The hospital of the University of Pennsylvania's new pavilion. The future of healthcare, here, now, ahead of its time.
Welcome, everyone. My name is Antoinette Brigidi, and I am Associate Professor of Clinical Medicine at the University of Pennsylvania. I serve as Chief Medical Officer for Penn Signature Services, which allows me to be part of this special collaboration with our London colleagues. I'm delighted to be here with you today to learn from our esteemed specialists. We have created a two-part series. Today, Dr. Marco Ruella will review CAR T therapy and the evidence since hitting the world stage. Dr. Varun Mehra will then discuss case examples. In our next session, Dr. Mehra will dive deeper into CAR T toxicities and sequelae. We welcome both specialists and generalists in our audience, speaking to the broad interest in this topic. At the end of each session, we'll leave time for questions. Please enter those in the chat as well as any audience responses requested by our speakers. And now let me please introduce our panelists. First, we have Dr. Marco Ruella. Dr. Ruella received his medical degree with honors from the University of Torino, Italy, where he also trained in hematology oncology. In late 2012, he came to the US as a postdoctoral fellow and then an instructor at the University of Pennsylvania in the Center for Cellular Immunotherapies under Drs. Carl June and Sarah Gill. He became an associate director of Dr. June's laboratory and in 2018 was appointed assistant professor of medicine in the Division of Hematology Oncology and the Center for Cellular Immunotherapies, as well as scientific director of the lymphoma program at the Hospital of the University of Pennsylvania. Still early in his career, Dr. Ruella has a stunning track record of awards and honors from the most prestigious and important organizations in his field for clinical cancer research. Most recent recognitions include the Gabrielle's Angel Foundation Award in 2020 and the Leukemia and Lymphoma Society Translational Research Program Award in 2021. Equally accomplished in his field, I'm also pleased to welcome Dr. Varun Mehra from London. Dr. Mehra is a leading consultant hematologist specializing in myelodysplastic syndrome, acute leukemia, bone marrow failure, autologous transplantation for autoimmune conditions, as well as allogeneic stem cell transplantation, immunotherapy, and post-transplant complications. Dr. Mehra completed his postgraduate specialist training at world-renowned King's College Hospital in London, where he has been a core member of a busy stem cell transplant and cellular therapy unit. Dr. Mehra's main research interests are in infections of immunocompromised hosts, graft versus host disease, and transplantation of autoimmune diseases, including cellular therapy strategies. He is published regularly on his disease-specific research interests in high-impact clinical and scientific journals. Dr. Mehra has developed exciting research collaborations and education within and outside King's Health Partners. His research spans bench to bedside translation opportunities. He's currently the education lead for King's Hematology Training Program and is a member of the KHP Institute of Hematology Education and Training Steering Group. And now I will turn to Dr. Ruella for the main presentation.
Well, thank you, Dr. Brigidi. I really appreciate the kind introduction and thank you for organizing this very interesting seminar. I'd also like to thank the London International Patient Services Group and Penn Medicine for making this possible. It's really a pleasure to be here with Dr. Mehra. And I will start today by giving an overview on the most recent clinical data and laboratory data on CAR T-cell therapies for cancer. These are my disclosures. So many of you in the audience and many of us are physicians, and one of the very common things that we see in our offices is patients with a mass, maybe in the neck, maybe in other areas. And of course, at that point, the next step would be to understand what the mass is about. And very often we do a biopsy. And when we do a biopsy, the type of results we have, for example, are shown here, where we look at the microscope and see a population of homogeneous cells. In this case, these are CD20 positive lymphoma cells, very packed. And what is interesting to notice is that when we look at also the marker CD3 that stands for the T cell, we do see that there are some T cells in the biopsies. And T cells in theory are supposed to protect our body from the uncontrolled proliferation of tumor cells. But clearly, despite the fact that they are inside the tumor biopsy, they're not able to control the growth of the cancers. So what does that mean? Well, it means that we need to consider cancer more like an immunosuppression situation, where we have a patient that would have potentially the ability to fight the cancer cells, but for multiple reasons, the T cells have failed to control cancer growth. And there are two main mechanisms that are shown here in the box by which the T cells are not able to recognize cancer cells. One is called central tolerance. In other words, the T cells that are in the tumor don't have the T cell receptor that is needed to recognize the cancer cell. They just don't have specific T cell that recognize cancer cells. The second mechanism is called immunosuppression or peripheral tolerance. And in this case, it means that the T cell can potentially recognize the cancer cells. They have the right T cell receptor, but they are immunosuppressed, so they cannot react against cancers. And so over the years, and in particular, I would say in the last decade, multiple types of immunotherapies have tried to harness back the power of T cells to fight cancer cells. I think many of you are familiar with checkpoint blockade, with many products, many antibodies against PD-1, against CTLA-4, PD-L1 approved for clinical use. But most recently, certainly CAR T-cell, T-cell engineered T-cell, TCR engineered T-cell, tumor infiltrating lymphocytes, and bispecific antibodies have been developed. And so today, we're going to focus on CAR T-cell and give an overview on the basic concept about CAR T-cell, but also the most recent updates of the clinical results. So what is a chimeric antigen receptor T-cell? Well, it's a T-cell. It's a T-cell that is characterized by the presence of a chimeric antigen receptor on the surface. And a chimeric antigen receptor, or CAR, is a fusion, is a chimera between a monoclonal antibody, and in particular, the variable domains that are the ones that allow the antibodies to recognize an antigen, and the T-cell receptor, and in particular, the CD3 zeta chain, which is the most important chain to trigger signal. So in other words, you have a single construct that you can see here in the red box, where you have antigen recognition as a monoclonal antibody, but then signaling as in a T-cell receptor. And this was the first generation of CAR. The actual generation that is now used in the clinic is called second generation because it includes a co-stimulatory domain. You can see here, for example, 4-1BB, another very common one is CD28, that really allows the T cells to get fully activated because they have signal 1 provided by the CD3 zeta, plus signal 2 that is provided by the co-stimulatory domain. So what is the difference then between a T cell that you can see here that expresses a CAR and instead a T cell that expresses a T cell receptor? Well, the first difference is that a CAR T cell can recognize antigens that are on the surface. So they can directly recognize the antigen on the surface without the need of presentation in the HLA complex. And this, of course, is an advantage because in many cancers, the HLA is downregulated. And so that could be a limitation for T-cell immunotherapy. However, CAR T-cell cannot recognize antigens that are inside the cancer cell. For example, you see this peptide here that is a part of our antigen can be processed and expressed through the HLA. And so one of the advantages of the T-cell receptor is that they can recognize cancer antigen that are also expressed inside cancer cells. What is interesting to notice that we're now familiar with CAR T-cell in the clinic, with cellular immunotherapies, but really the first concept about merging an antibody, as you can see here, with a T-cell receptor was actually developed in the late 80s by a group in Japan, 1987, and another group in Israel, 1989. And it took literally 30 years to get from the initial concept of a CAR to the FDA approval of the first gene therapy for cancer that is called tisagenlecleucel, that was developed initially at the University of Pennsylvania and then brought to the market by Novartis. And so in August 2017, again, exactly 30 years after the first publication, Kymriah was approved for pediatric and young adult leukemia. And in May 2018, was also approved in lymphoma, thanks to the work of the Penn group with Dr. Steve Schuster leading the trial. Now these products, including others that we'll see in a second, are approved in many countries in the world. So it's very exciting to see that now we can use this cell therapy in multiple areas. This is, I think I always like to show this photo because it was an important day. This was the day when at Penn, we received the news of the approval of tisagenlecleucel by the FDA. And so, of course, there was a big party. You can see here Carjun. This is the cancer center director that were really big players, and Mike Milone, and this is the current CEO of the healthcare system. And so a big party and big sort of teamwork to get this approved. And of course, I was traveling. I was actually in Europe, so I decided to Photoshop myself here. So that's me in the picture. So I'm part of the party. And a lot of things have happened since 2017. We have now hundreds of clinical trials all over the world. You can see that I've recorded the number of trials from 2015 to 2022 by searching chimeric antigen receptor in clinicaltrials.gov. And you can see how many trials are now ongoing all over the world, with China really being the leader with more than 500 trials, and North America, US, and Europe. We have now 4 CAR products for B-cell leukemia and B-cell lymphoma. You can see them here with their indications. Tisagenlecleucel, the Novartis product approved for pediatric and young adult ALL and for large cell lymphoma. Breyanzi, this is the BMS product for large cell lymphoma. Yescarta for large cell lymphoma and follicular lymphoma. And Tecartus, which is very similar to Yescarta, just a different manufacturing process, approved from mantle cell lymphoma and adult acute lymphoblastic leukemia recently in October. So it's a very exciting time with multiple products coming to the market. There is also one product for multiple myeloma that we will discuss later. But again, one of the reasons of the success of this therapy is that we are able to target CD19. And CD19 is an optimal target because it's expressed throughout B-cell maturation. And so it's highly expressed in acute leukemias, but also differentiated B-cell lymphomas. But moreover, the expression of CD19 is only restricted to B-cells. And we know that with the right precautions, patients can also live without B-cells, getting immunoglobulins and managing infection. So again, the first products were developed against CD19. So how does the system work? Where I'm going to show you a cartoon here and then a video just to show quickly the concept of how we modify patient T cell to make them CAR T cells. You can see here that we have a T cell from a patient, and these T cells are collected, they are transduced using a lentiviral vector that brings integrated the sequence of the CAR. And now the T cell can express the CAR construct on the surface, in this case against CD19, for example. These T cells are now infused back to patients, and they can recognize CD19 on the surface of cancer cells, leading to the death of the tumors. Obviously, this is a cartoon. I also want to show you the actual way that they work in the clinic. So this is of course done in the lab, but you can assume that the same happens in patients. So you can see here, this is a T cell, is a CAR T cell binding to a cancer cells, and you see that all this blabbing is the tumor cell that is dying. So again, the CAR T cell recognizing, forming the immune synapse, and you can see here all the two cancer cells actually dying. So as you may imagine, this T cell, after having killed these two cells, can go to another one, and keep killing. So it's really a different concept for cancer therapies, where you're injecting a live agent that will be able to traffic, find the tumor, kill the tumor, proliferate, activating the immune system, and persist at long term. This is a snapshot of the clinical manufacturing, one of the many different clinical manufacturing that have been developed. But the main concept is that T cells are collected from patients, they are activated, they are transduced with the lenti or retrovirus, and then the cells are kept in culture for about a week, 10 days. The beads that we use to activate the T cell are removed, and then this product is now ready for the clinical use. At the right time, it's going to be infused into patients after a lymphodepleting chemotherapy. And so I mentioned that there are several products, 4 products against CD19 that have been approved, at least in the US, by the FDA. And the first one was Yescarta, very similar to the Tecartus I mentioned. They have just different manufacturing processing. Kymriah is the Novartis one, and Tecartus and Yescarta are manufactured by Gilead, and Breyanzi is the Myebens product. They are very similar. In other words, they all use the same SCFV. This is the antibody portion of the CAR. The real main difference is the co-stimulatory domain, where Yescarta and Tecartus use CD28, while Kymriah and Breyanzi use 4-1BB, as you can see here, and as you can see here. And I think the reason of the success of this therapy, I think, is exemplified here in this picture. Emily Whitehead was a girl, and now is a teenager actually, who had acute lymphoblastic leukemia, and she was treated with CAR19 at the Children's Hospital of Philadelphia by Dr. Steve Graff. And she was able to get into remission despite the fact that she had multiply relapsed leukemia after transplant, very refractory disease. And now she's going to be 10 years in remission in April. And you can imagine this event, the fact that we were able to cure a patient with advanced leukemia, really helped sort of pushing the field of CAR therapies forward. And of course, that's a beautiful story. There is now a foundation that is doing great work in the field, but obviously, in order to get a product approved, you need more data. And what you see here is actually the data of the global registration trial of Kymriah, tisagenlecleucel. This is the Novartis 4-1BB product, initially developed at Penn. And these are the data in 75 patients, where 81% of patients treated achieved a complete response. So really amazing results for patients with relapsed refractory acute lymphoblastic leukemia. And these were patients that were up to 25 years old of age. And you can see that the event-free survival shows that many patients are able to keep their remission during follow-up, but yet some of them relapse. What is the reason of the success of this therapy? Well, an important feature, as I mentioned earlier, of CAR therapy is that you're really injecting a live agent. And you can see that from time of infusion to a few days later, you have a huge exponential expansion of these CAR T cells in the peripheral blood. Each line is a patient. And you can say that after this huge expansion in the first month, there is a contraction when the leukemia is cleared, and the majority of patients will keep the expression of the CAR in their T cell at long term. And again, for example, Emily now is 10 years out of her CAR therapy, and she still has circulating CAR19 cells in her peripheral blood, which probably have been key to maintain the remission at long term. But I mentioned to you that CAR therapy is also very effective in lymphoma. There are three main products for diffuse large B cell lymphoma, which is an aggressive form of lymphoma. I mentioned Yescarta, this is Kymriah, and this is the Breyanzi product. As you can see here, the complete response rate are quite similar. Between 40 to 50% of patients will show a complete response. And if we want to take a look at actual patients, you can see one case here. This is again acute lymphoblastic leukemia. You can see the effect of the T cells in the peripheral blood and in the bone marrow. This is, for example, the bone marrow where you have no CAR T cell at baseline, and then you have 80% of the CAR T cell in the bone marrow being CAR positive, 80% of the T cell being CAR positive. And at the same time, the leukemic cells that are here double positive for 19 and 20 are then cleared at day 23. This is a leukemic patient. I want to show you a B cell lymphoma patient that is shown here, a PET scan, a lot of disease in these lymphnodal sites. A month later, complete remission. So pretty fast and strong anti-tumor activity. If we look at the three products that are approved for large cell lymphoma, you can see that despite the fact that some of them are using CD28 co-stimulation, some of them are using 4-1BB, and they have slightly different manufacturing process. Overall, the overall survival in the top row and the progression-free survival, the bottom row, are very similar, with about 30 to 40% of patients that are in remission at long term. We recently published an update of the first single center trial of Kymriah in lymphoma. With the 5 years follow-up, you see in diffuse large B cell lymphoma, you have 30% of patients that are in remission. In follicular lymphoma, about 40%. Interestingly, as I mentioned, this therapy is now being used also in other type of lymphomas. For example, these are the data in mantle cell lymphoma using the product that I mentioned as Tecartus. Very high response rate, 93% overall response rate, with an astonishing 67% of complete responses. And you can see here a very good progression-free survival curve with about half of the patient being able to maintain their remission at least a year later. But CAR T cells are also being used in other lymphomas. This is an example of the use of Yescarta in follicular lymphoma and mantle cell lymphoma. Very nice responses, as you can see here, in overall survival, and in particular for follicular lymphoma, which is the blue line, pretty promising progression-free survival. less so for marginal zone lymphoma, I would say, but very strong for follicular. And this data actually led to the approval of Yescarta for follicular lymphoma. Interestingly, other products are being tested for follicular lymphoma. For example, here, these are the data of Kymriah. Again, a very nice progression-free survival curve and a beautiful overall survival curve. And so we expect this product also to be approved in the next few months. But I'd like to give you a snapshot also of other diseases, and in particular, myeloma, multiple myeloma. There is one product that is approved in the setting of myeloma. It's called Abecma or idecaptogene picluso. This is the sort of the design is again a 4-1BB based CAR with an anti-BCMA scFv. These are the response data. You can see up to 80% overall response rate with about 40% of complete responses, which is very promising. However, for this product, I think the long-term data, as you can see here, of progression-free survival, they show that even a year later, there is really only a fraction of patients that is able to maintain a response. So again, clear signal that it's working, but probably we have an issue of long-term efficacy. Another product is about to be approved probably within the next week. It's called ciltacabtagene autoleucel. It's a slightly different construct as a two antigen binding domain. These are variable heavy chain. Each one of them can bind to a different epitope of the BCMA. They have 4-1BB. And these cards have shown really an astonishing rate of responses with 98% overall response rate and 80% of complete responses. And you can see in this case, this product shows pretty good ability to maintain a response at long term, at least at a year later. Of course, we need to have more long-term data, but certainly is very, very promising. But I want to conclude my talk by thinking a little bit about the mechanism of relapse. I've shown you a lot of data, clinical data to sort of support the fact that CAR T-cells are very effective, at least in B-cell neoplasm and myeloma. But we also need to realize that still a significant portion of patients that you can see here in yellow, in both ALL, lymphoma, and we can say the same for multiple myeloma, are eventually going to fail this treatment. And so we need to understand better the resistant mechanism in order to make more effective approaches. And we recently published here in the British Journal of Hematology a review that summarizes the main causes of failure of CAR T-cell immunotherapy. And there are several ones, but there are even, I think, barriers to the success of CAR T-cell before infusion. For example, and I think here is somewhere where LIPS is working hard on, the access, having access to therapies that are not available in certain countries, but available in other countries. It's an issue. The costs are issues, but importantly, the progression during manufacturing. When we wait for patients to receive CAR T-cell, they might progress and they might not be able to wait for the CAR infusion. And some patients cannot manufacture CAR T-cell because they have either low lymphocyte counts or the manufacturing fails. But beside these sort of barriers that are sort of less biological and more logistical ones, I think there are three main biological reasons for failure. One is the CAR dysfunction. So the T cells do not do their job. The immunosuppressive microenvironment, which is partly connected to the fact that the T cells don't work. And what we call tumor intrinsic mechanism, which are basically changes in cancer cells that lead to failure. And so I will just conclude with a snapshot of each of these mechanisms, sort of to stimulate discussion later. So let's start with the tumor intrinsic mechanism. Tumor intrinsic mechanism can be, for example, the fact that the tumor cell expresses PD-L1. And so PD-L1 will interact with PD-1 and will inhibit T cell function. But what I want to show you today, which I think is one of the most common mechanisms in leukemia and also in lymphoma, is antigen loss. So basically the tumor cells that are initially CD19 positive at baseline, they lose the expression of CD19 over time. I just give you an example here. This is the expression of the CD19 in leukemia pre-CAR, and this is the expression after CAR. So you got basically the leukemic cells going from positive to negative. And interestingly, as you can see here, I've kept updating this percentage in pediatric leukemia is about 75% of the relapses. This is very, very high. And we are now sort of realizing that I think about 30%, 30 to 40%, or even more patients in lymphoma are also characterized by reduction or loss of CD19. So very important issue. So how do we deal with it? How do we prevent antigen escape or treat antigen escape? Well, certainly we need to target additional antigens. And just to give you a snapshot of where the field is going, very soon the field is switching from a single CAR concept to CAR T cell concepts that target multiple antigens. We have a trial at Penn with a pool CAR concept where we're putting together CAR19, for example, and CAR22. So you are targeting 2 B cell markers in leukemia. Other groups, and hopefully we'll do it soon, have developed dual CAR. So the same T cell expressing 2 different CARs. And lastly, the so-called tandem CAR. So this is a single CAR with 2 SCFVs, 2 antigen binding domain that we recognize 2 different antigens. But if we think about it now, we have also the ability to make, for example, a CAR T cell expressing 1 CAR, but secreting a bispecific antibody that targets another antigen. Or probably even an even easier strategy would be to use a CAR product, let's say CAR19, and then adding a bispecific antibody against CD20 or another target, so that you have basically the ability to do dual target. Let's now switch to the CAR dysfunction. This has been pretty clear, and this is one of the studies where our colleagues here at Penn have analyzed in CLL patients with complete response, patient with partial response, and patient with non-response. And as you can see here in this heat map, and these data are confirmed here in this box plot, in complete responders, you have less exhausted cell, so less T cell exhaustion. You have more naive cells, so cells that are less differentiated. And interestingly, you also have reduced glycolysis, reduced hypoxia, and importantly, reduced apoptosis. So the quality of the products, the quality of the T cells of each patient do influence the activity of our CAR in patients. So again, just a snapshot to show you how we can leverage this knowledge to make the CAR T cell better. Well, we can use small molecule, for example. In 2016, we published a proof of concept work that you can combine a BTK inhibitor, ibrutinib, with CAR T cell, and you can achieve the objective of targeting cancer cell using a small molecule and an immunotherapy. But most importantly, early studies, including ours, show that ibrutinib can have a beneficial effect on CAR T cell by inhibiting ITK. And so based on this data, a clinical trial was run at the University of Pennsylvania. And you can see that in a chronic lymphocytic leukemia that usually does not respond very well to CAR T cell, we got very nice reduction in target lesions, but even more convincingly are the data on the complete response to the bone marrow, with at 1 year, 91% of patients being in complete remission. And this was by flow cytometry. You can see here the reduction of CLL cells from baseline to 3 months, but more importantly, by deep sequencing, where you can see the baseline values and the 3 months. So very, very deep responses by combining small molecules with CAR T cell. And I'd like to conclude with talking about the tumor suppressive microenvironment. Many players are there. The physical barrier to T cell from entering the tumor, soluble factors, IL-10, TGF-beta, Tregs, that regulatory T cells that can inhibit CAR T cell myeloid cells, like tumor-associated macrophages or myeloid-derived suppressors. And this topic of the effect of the microenvironment is particularly important in solid tumors, in the development of CAR T cell against solid tumors. You can see that now most of the trials are targeting B cell or multiple myeloma targets, but now some targets and many studies are now ongoing, try to use CAR T cell for solid cancer. For example, mesothelin is a common target, HER2, GD2, EGFR, V3, and many others are now being explored as potential targets for solid cancer. Certainly, we don't have a CD19-like target for solid cancer. So there is a lack of optimal target in solid cancers. But the other important point in solid cancer is the immunosuppressive tumor microenvironment. You can see here there are so many players that can inhibit the function of CAR T cells. One slide to show proof of concept that if we use them the right way, you can actually get responses, even in solid tumors, is shown here in a patient with glioblastoma. The group at City of Hope showed that you can develop a CAR that targets the interleukin-13 receptor alpha-2. And the interesting approach that they use here, they use a implanted device to inject directly the CAR T cell in the brain in the liquor, and you can see that by doing this with the intraventricular injection of your CAR, the patient was really able to see significant reduction, as you can see here, of the lesions in the brain, also the lesions in the spine were sort of cleared, and you can see also the data here. So clearly, these were temporary responses, okay? The patient then unfortunately relapsed and died for the disease, but show proof of concept that probably changing the delivery mechanism, you can actually get responses also in solid tumor. So I've shown you many data, but the general concept, the takeaway messages are that CAR T cell can break indeed the immune tolerance and lead to responses in relapsed refractory cancer patients. We have at least 5 products approved in the US by the FDA for B cell lymphoma, B cell leukemia, and multiple myeloma. The future would be probably in CAR T cell targeting multiple antigens, or CAR T cell combined with small molecules to increase response rates. And there is still a lot of work to do to sort of solve the issue of CAR T cell for solid tumors. Another important topic that I intentionally didn't discuss today is the topic of toxicity that will be discussed in the next webinar by Dr. Mera. I would like to conclude that I would like to thank my laboratory and Penn in general. We are always hiring postdoc. We have actually bioinformaticians needed. So if you know anyone, please feel free to reach out to me at my email. And then I think I'm gonna leave the microphone to Dr. Brigidi, and I would like to thank everyone for the attention.
Thank you, Dr. Ruella. That was so very informative. I wonder, I could start off, I welcome any questions from the audience, and I have a couple. Maybe I could get started before we ask Dr. Mera to walk through a couple cases. If you don't mind, Dr. Ruella, I wonder if you could say a bit more about how long the time frame typically is for a patient between when they may receive a diagnosis and actually being infused, because I saw that there's this manufacturing stage, and I know patients can sometimes be quite ill. Oh.
It's a very, very important point. As I mentioned, fortunately, some of the patients do progress while we wait for the product. So I have to say, since the approval of the first products, it has been improving for many reasons, logistical reasons, changing manufacturing and so on. But still, it takes a few weeks. So between the decision to do CAR therapy and you need then to get the apheresis done, and that takes time to book it. And so you lose about a week to book the apheresis. And then it takes anywhere from, if you're really super lucky, 15, 17 days to 30, 40 days to wait for the product. So it's certainly a long time for a patient with an aggressive cancer. And so for some of the patients, we do use that additional therapy. In the meanwhile, we do the so-called bridging therapy to sort of maintain the disease while we wait for CAR infusion. But in general, the field is moving towards shorter manufacturing times. And there are now groups that are doing 3 days, 5 days, 2 days, 1 day even. And so hopefully that will allow us to reduce the time between the decision to do CAR T cell and the actual infusion of CAR T cell. Certainly allogeneic products can facilitate all of this by providing an off-the-shelf product, but we're not there yet. I mean, studies are ongoing.
Got it. Understood. Thank you for that. Dr. Mera, did you have something to add?
No, I think you just covered, thank you, Dr. Ruella, the allogenic product. I think this is a problem, as you rightly said, the delays between, identifying a patient, eligible patient, and then trying to get through them for the CAR T production and then eventual infusion, can be quite a challenging time for some of these patients. They relapse. So I think the off-the-shelf allogenic product is really, is quite kind of exciting in that way that you could probably just kind of, do it more rapidly. But, as you said, clinical trials ongoing, and I just want to kind of raise that point that there is definitely work towards that that is happening. So yes, you already covered that. So thank you, which is an important thing to think about in future.
Okay, and I wonder, I don't see any more questions. Dr. Mera, would you like to go ahead and start with your cases?
Yes, absolutely. No, thank you. So I think it would be, very difficult. So I think fascinating talk by Dr. Ruella, but I thought it'll be useful to put this in context in terms of, yes, we have these cases, these patients who are refractory relapse type of disease, and we've got this very novel, clever technologies coming through, and we are treating these patients. But in real life settings, we often are faced with challenging cases where the decision making has to be thought through quite carefully as what is the best strategy for some of these patients. So I thought I'll bring along some couple of cases and take opinion from the team, people who have joined in, and see what they all feel we should be doing or should have done. And of course, have input from Dr. Ruella himself for his expert opinion to see what he would have considered for some of these cases. So for this one, I had, let me just take my hand down. Yeah. So it's a 78-year-old lady, quite fit actually, with a good performance status. They're all real cases, bear in mind. So fit lady who unfortunately diagnosed a few years ago with stage 4B diffuse large B cell lymphoma, has standard care, R-CHOP, full dose chemotherapy despite her age. She was quite biologically fit, so we chose to give her good R-CHOP standard treatment and intrathecal methotrexate because of stage 4B disease. She achieved complete metabolic remission with no complications and was monitored. Unfortunately, she relapsed again in January 2020 with abdominal disease, and this time we gave her R-bendamustine polatuzumab combination for 6 cycles and achieved complete metabolic response. Again, a quite kind of a good, strong combination for such age group patient, but she tolerated it well and achieved a response with that. In the meantime, she had some pancreatitis problems and had lateral cystectomy and was being monitored. But just a year later, she presented again with back pain and abdominal pain and found to have bulky retroperitoneal mesenteric lymph node and class as stage 2 disease with a raised LDH, and biopsy again confirmed a same disease process. So clearly, unfortunately, the year after other, she could not sustain her remission despite having an initial good response. So really posing a bit of a challenge that, what we do with this sort of patient, how far we take her treatment to, can she cope through more treatments? She already had 2 strong cycles of chemotherapy year after year. So really, the questions I wanted to check if you would consider doing, I can't move the slides, I guess. Just need the next slide, please, if someone can help me. Yeah, so the options really that we had to consider at the time, would you actually go through another salvage chemotherapy followed by a stem cell transplant, allogeneic stem cell transplant, which is not a wrong thing to consider because, having a relapse twice, you would probably want to consolidate with autocrat, which would have been a standard practice anyway, pre-CAR T era, or you would just think it's not likely going to work because clearly her chances of staying in long-term remission are pretty grim, and then perhaps time to think of palliative approach and achieve more quality of life to whatever small period she may have, or go down the route of CAR T therapy in this instance. And really, it's a question to the audience and as well as Dr. Ruella really is what would be the right approach in such cases, being older, having multiple disease, and refractory sort of disease, what should be the right thing for her? Any thoughts? You're free to, with the options, audience can just type in the chat screen to what they would suggest would be the better way of managing this patient in their view. That's a real life dilemma we have to face often in these sort of patients who are not really, standard, young, fit patients, and we just throw everything at them. Sometimes we have to take a step back and think what would be the right approach for them.
Yeah, it's a challenging situation, right? It's clearly a disease that tends to relapse, and I definitely would exclude option B, palliative approach. I think there is still room for treatment in this patient. Of course, it depends also on what products are available for CAR T cells and what are the indications. So if you can use before transplant, which is not always the case, probably a few years ago we would have tried to do the autologous transplant, and the more data we are achieving and we're achieving now in the setting of comparing CAR to autologous transplant, I would be leaning towards the CAR therapy, but obviously it depends. I know in the UK, can you use a CAR product before a transplant? Before an
we can, yeah, we can. So anything more than second line, failure to second line, we can use pre-CAR T, pre-autograft. But of course, patients have had autografts in some scenarios, so they're also allowed to have post-autografts. But allogenic is a bit of a gray zone, which often is a difficult one to get approved.
One thing to consider, Dr. Mera, as you know very well, it depends also on the tumor burden, aggressiveness. You don't want to do CAR T cell when the disease is sort of out of control and there is a big mass, because the chances of that disease to respond is very low when you have high LDH, high tumor burden, and then you can get a lot of toxicity. So certainly some sort of approach to control the disease and then rapidly move to CAR T cell. That's what I would do.
Yeah, I think totally agree. I think that's what we did with this bridging therapy that we gave her, and then chose to kind of go down those CAR T therapies. But next slide. The next question really, which agent would you then go? Because obviously we've got Kymriah. We talked about the data that we had in terms of response rates. You know, clearly, if you look in a bit more detail about subcohorts within the trial, you know, older patients versus younger patients, toxicity data, you probably need to start thinking through again, you know, really which agent is a better approach for this. So which one would you think you would go for if you were to choose between the two? We have available both for the same indication in the UK too. We don't have the liso-cel available to us with just these two CAR T products that we currently can use in this.
Yeah, I see someone from the audience also commented on the option and say agree option A and then go to CAR T. So, you know,
good. That's good.
Well, you know, you can add here, if you were in the US, you would be able to add Breyanzi, so the BMS product. I don't think we have data, right, to say which product we can use. There are not randomized trials. Any study that has been done, you know, all these studies have slightly different criteria for eligibility. For example, for Yescarta, bridging therapy was not allowed. For Kymriah, it was. So it's really hard to design and to decide. You know, for sure that Kymriah seems to be less toxic. Kymriah and Breyanzi seems to be less toxic than Yescarta in general. But I don't think we have data, and it should be a decision that is made center by center and patient by patient. Also thinking about inpatient versus outpatient treatment based on the toxicity. So it's usually a decision that is made based on the policies of the center and patient and also product availability.
Absolutely spot on. I think this is, as you said, there is no randomized direct data, and we probably will never have one in terms of how these agents behave. There will be minor differences, but I think generally, as I said, you know, the tolerance for Kymriah is a bit more than the Yescarta, for example, in the older group of patients. In our experience, in our center, we've done around 200 CAR T sort of infusions in the last couple of years, and then, you know, overall we feel, you know, for older patients, you know, Tisagen or Kymriah is probably a bit more better sort of tolerated approach. But, you know, if you're looking for higher efficacy, more response rates, then perhaps Yescarta could be a better product in that instance. It's just very much what goals we need to achieve for that patient, discussion with the patient about toxicity risks, and ultimately, you know, have that sort of multidisciplinary approach to decide them. Right, thank you. So, moved on quite fast here. So second case, which will be hopefully a quick one. So this is a gentleman, 45-year-old, who is young, fit, no comorbidities, but has background of HIV for many years, well controlled on antiretroviral therapies, but unfortunately got diagnosed just a couple of years ago with stage 3S, the diffuse large B cell lymphoma with IPI score of 2. During that time, she was given standard chemotherapy with R-CHOP. He had CMR on PET scan at 3 cycles, and cycle 6 unfortunately had to be withheld because he developed asymptomatic COVID infection. Bear in mind, COVID has been a big player affecting a lot of our treatment plans in the last couple of years. So unfortunately he got COVID, so we could not really go ahead and give him cycle 6. So we kind of thought we'll just wait, but unfortunately that didn't work well. He had an early relapse with a regrowth of left axillary and pectoral necrotizing mass, confirming against lymphoma. At this time, his COVID-19 sort of PCR positivity was negative. We then decided to go ahead with RGDP treatment, for which he received a good partial response after 2 cycles, and then eventually a complete metabolic response after 3 cycles. But during this time, we were noting on the PET scan that there was some worsening ground glass changes, perhaps from his COVID infection that he had, which was gradually coming through. Unclear why. Is it related to the immunosuppressed state at the time, that he may have some residual COVID infection in the background? We thought at this time perhaps do an autograft, so we harvested him with GCSF, but during this time he then came in with positive COVID infection again, and we had to delay his autograft at this time. And while we were waiting for him to recover through that again, and this is when we were having the second wave in the UK, we had this problem. The PET scan became positive again in the same site of the previously biopsied left axilla. So kind of stuck really, because he's got this COVID in the background. He's got this progressive disease, initially thought autograft, but not really going anywhere. But it's got localized disease relapse coming through. So what's really the best approach for such patients? You know, would you actually still go ahead with the autograft? Would you consider local radiotherapy and just watch and wait for some patients like this to have a local control and wait for the COVID issues and everything to be sorted out and then decide? Or would you actually think of, you know, maybe he's more better suited with CAR T therapies and autograft won't hold his disease, and then consider that? Or again, you know, age-old question, should we actually then have a palliative approach, considering he had a very rapid relapses one after the other? And I think, in my view, the thoughts to consider would be this COVID-19 issue. And just wanted to hear your thoughts about the HIV positivity, and where do we stand for CAR T in these scenarios? Because clearly the trials excluded HIV positive patients. And do you think there's a role to still consider these patients for CAR T therapies?
Dr. Mera, I wonder if you, in the interest of time, since we're at 2 o'clock,
right.
if you could just let us know your thoughts, and then we can thank our guests.
All right, sorry, apologies, taking longer. Discussions always take longer. So I think,
yeah, it's been a great discussion.
Absolutely, the CAR T, you know, is probably an option, and I would have definitely considered him with well-controlled HIV. And even though it's not clinically in the trials, but we have approvals in the UK to consider case-by-case basis. But clearly, we wanted to kind of treat his underlying disease while COVID-19 was the problem. So we ended up giving him local radiotherapy and waited for 3 months, and then eventually performed a CAR T on him. So that's how we kind of managed him. By that time, he was 3 months, which is the minimum recommendation for waiting for COVID-19 to clear before cellular therapies are given. And that's what we took an approach for. But just highlighting the point that HIV positive patients are some of the cohorts that has been missing out on some of the CAR T therapies, and a lot of centers across different countries have not had approvals for that based on the clinical trial data. So something to really fight for. But yeah, thank you for listening.
Thank you both so much. That was a great discussion. And there were so many threads there that I know we will pick up for the second part of this series. As you mentioned, patients for whom we could consider this therapy. So thank you both, Drs. Ruella and Dr. Mera, for this discussion. And to our audience members, we hope that you'll join us for part 2 when we talk more about CAR T therapy and toxicities and long-term sequelae. Please keep an eye out for that date. Thank you again.
Thank you. Have a good